Hello and welcome to the scrotal mass scheme. Today we'll be discussing inguinal hernias, especially the differences between indirect and direct inguinal hernias. Here is the relevant reading assignment for the Indirect Inguinal Hernia podcast, and you'll see that this is an ebook. You can either access it by rolling over it until you get the icon that says you can click on it. When you click on it, it should take you right to the text. If it doesn't, you can try the link that's included in the notes section, and if that fails, just go to the library website, go to the ebook section and type in Sabiston Textbook of Surgery. You'll go to chapter 46 and read at least through the part that has the figure 46-4. The rest of the chapter is interesting and has a lot of surgical implications, but for the anatomy part of it, you can stop there. Also, I have included the optional reading from your clinically oriented anatomy textbook. Here are the learning objectives. If you'd like to pause now, you can read through them, or you can come back and review them later. And so here we have an image that I'd like to use to start this webcast, and we see several different kinds of abdominal hernias in this image. This is not all inclusive. There are others, and if you go further into the reading assignment, then you can read more about the other ones. Today's focus is going to be inferior to the umbilicus, and mostly over here when we're talking about the inguinal hernia. But quickly, I wanted to delineate the differences between the femoral and the inguinal hernias. So, the femoral hernias will occur inferior to the inguinal ligament, which would be right about there. So, femoral hernias inferior to that inguinal ligament, and they will follow the path of the femoral vessels, whereas the inguinal hernias occur superior to the inguinal ligament, and they account for about 75% of abdominal hernias. The vast majority of those will occur in men. Females, on the other hand, are more susceptible to femoral hernias. But that's all I'm going to say about the femoral hernias. It will be important to distinguish between the direct or acquired versus the indirect or congenital inguinal hernias. And here we have the scrotal mass scheme, and today we'll be focusing over here on the painless side of things, and under the does not transilluminate node here we have, there's scrotal mass, and there's our focus today, inguinal hernia. So that's our scheme. So we will recall this slide from Anatomy of the Testes, and remember that the testes, during their descent, pushed layers of the abdominal wall in front of them, and during that oblique passage from the abdomen into the scrotum, they also brought along with them the processus vaginalis during the descent. And that processus vaginalis, if you'll recall, is the connection back to the peritoneal portion of the abdominal cavity. But at the time of birth, or right around that time, the testes have fully descended into the scrotum, and the processus vaginalis closes off. And at that time, there's only a small isolated remnant of the peritoneal cavity, and that's the tunica, the cavity of the tunica vaginalis. If, however, the processus vaginalis does not close, or for some reason gets reopened, then there is the potential for abdominal contents to herniate through the patent processus vaginalis. So those abdominal contents could be a loop of bowel, they could be a piece of omentum, or even the urinary bladder. And so this again is a slide showing a simplified sagittal view, showing the processus vaginalis as it has become obliterated. And we looked at this slide when we were studying hydroceles, and that the processus vaginalis can be reopened, and then there's peritoneal cavity from the abdominal contents all the way down into the spermatic, through the spermatic cord and into the testis. In this case, there is the potential for a loop of bowel, such as this, to herniate down through that processus vaginalis and end up all the way down into the scrotum. So that was a rather simplified view of the processus vaginalis, and we want to see next the a better view, an anterior view, so that we can see the real path of a indirect inguinal hernia through the abdominal wall. And so for that we need to have a better understanding of the anterior abdominal wall, and I want you now to look here and see that this is the location of the inguinal canal right here, demarcated by the purple dotted line. And so I want you to note that there's a difference between an inguinal ligament and an inguinal canal. The inguinal ligament is this inferior free margin of the external oblique aponeurosis, and recall that it spans the distance from the anterior superior iliac spine down inferiorly and medially to the pubic tubercle. So that is the inguinal ligament. The inguinal canal, on the other hand, is a tubular structure, and it's responsible for conveying the spermatic cord, or in the case of the female, the round ligament of the uterus. Okay, so this inguinal canal is also the pathway by which an indirect inguinal hernia can leave the abdomen. Alright, so it's a canal, or it's a tube, so it's going to have two openings. And if we start internally, where a loop of bowel could get started, then it first would pass through this structure right here, which is called the deep inguinal ring. And the deep inguinal ring is a defect in the transversalis fascia. And if that loop of bowel continued through the inguinal canal, it could then exit through the superficial inguinal ring, which we see right here. And the superficial inguinal ring is made up of a medial crus here and a lateral crus here, and those two crura are held together by intercrural fibers right there. So the next thing I want to point out is this artery right here. And so I want to ask the question, why did the artist take the time to draw in this little bit of this artery? Well, the answer is that this artery is the inferior epigastric artery, and it's going to help us in our ability to diagnose what type of inguinal hernia that a patient will present with. So the inferior epigastric artery is a branch off of the internal iliac artery, and if we have an inferior epigastric artery, then sure enough, here we have a superior epigastric artery. And so these two epigastrics will anastomose with each other, either within or posterior to the rectus sheath associated with the rectus abdominis muscle. Alright, so now let's take another view. This is an anterior view. Next we want to see a view from within the abdominal content. So now we're inside the abdominal cavity and we're looking anteriorly. And again, we see the inferior epigastric artery and its accompanying vein right there. And if we look just lateral to where these guys branch off of the external iliacs, we're going to see this right here is our deep inguinal ring, which is that defect in the transversalis fascia. So transversalis fascia would be the fascia that lines the transversus abdominis muscle from the internal aspect. Okay, so this is an important relationship, the deep inguinal ring being just lateral to the root of the inferior epigastric vessels here. Now, if we look just medial to the deep inguinal ring, so we're going to follow this medially about 4 centimeters, we're then going to see the location of the superficial inguinal ring. We can't see it from within the abdominal content, but we saw it from externally. So the superficial inguinal ring is right here. Now from this view, we can see another weak spot in the anterior abdominal wall, and that is the inguinal triangle, shown right here. So the inguinal triangle is also known by the eponym of Hesselbach's triangle. And in anatomy, if we have a triangle, then we're also going to have boundaries. And here they are. So the medial boundary of Hesselbach's triangle is the rectus abdominis muscle. And the lateral border of this inguinal triangle is the inferior epigastric vessels. And then the final, in the inferior border, is going to be the inguinal ligament right there. So this entire triangle is medial to the inferior epigastric vessels. So if a hernia pushes directly through this weak spot, it is known as a direct inguinal hernia here. as opposed to if an inguinal hernia takes an indirect route or the oblique pathway following the original route of the testes descent. So the indirect inguinal hernia would push through this deep inguinal ring here. So that's the difference there. Now let's take another look at that and see the difference. So if we talk about the a direct inguinal hernia sort of bulging right here, and again here's that inferior epigastric vessel, so this would be bulging just medial to the inferior epigastric, and so the direct inguinal hernia will leave the abdominal region medial to the inferior epigastric vessels. Now, it can just bulge right here, or a direct inguinal hernia can also push through the superficial inguinal ring, which we see located here. So it can push through that superficial inguinal ring even though it didn't go through the deep inguinal ring, which would have been here. All right, and so that's the difference, because when we look up here to see the indirect inguinal hernia, we note that in this case the loop of bowel pushed first through the deep inguinal ring, then went through the inguinal canal, and then pushed its way through the superficial inguinal ring to gain access to the scrotum. And again, now we want to take a look also and note that this passageway, the abdominal contents left the abdominal cavity lateral to the inferior epigastric vessels. Okay, so this is another image that is a review. This is where we demonstrated that the testes pushed obliquely through the abdominal wall, pushing some layers or coverings and pulling other structures along with it. Now, I want you to note the inguinal canal would be in between the deep inguinal ring here and the superficial inguinal ring there, both demarcated by the dotted lines. And let's take another look, this time an image from Netter's atlas, and we're going to show that this is a really nice image showing how the spermatic cord travels through the different layers that make up the passageway of the inguinal canal. And so recall again that the canal is a three-dimensional structure, and it's got a pathway with specific boundaries, and this is important. And let's take another look here at those boundaries of the inguinal canal. So with an inguinal canal, of course, I said that it's going to have an opening on two ends, and that would be the superficial and deep inguinal ring. So that part's easy. The deep boundary of the inguinal canal would be the deep inguinal ring, which we see right here poking through the transversalis fascia, and the superficial border of the inguinal canal would be right here, the superficial inguinal ring. And now again, since it's a structure, it's going to have other borders as well. So it's going to have a roof, an anterior, a posterior, and an inferior boundary. So let's start with the roof, and we see the roof of the inguinal canal is going to be both the internal oblique muscle fibers right here, and just posterior to that, the transverse abdominis muscle fibers, and they arch over the inguinal canal to form the roof of that inguinal canal. So from the superior, let's move anteriorly, and the anterior boundaries for the inguinal canal are going to be the internal and external oblique aponeuroses. So we can see the external oblique here, and we can follow that, and here's the aponeurosis, and making the anterior border of the inguinal canal, and the internal oblique also participates in that anterior border. Now, it's difficult to see in this image, but the inferior is going to be made up of, or the floor of the inguinal canal is going to be made up of the inguinal ligament as it curls under and makes a floor for the inguinal canal, and also a portion of the inguinal ligament that has a special relationship with the pubis, and that's called the lacunar ligament. And then the posterior boundary of the inguinal canal is going to be made up of the conjoint tendon, and we see the conjoint tendon right here. The conjoint tendon is made up of the aponeurosis of the internal oblique as it conjoins with the aponeurosis of the transversus abdominis. So you can see that transversus abdominis and internal oblique come together to form the conjoint tendon, and that forms the medial portion of the posterior wall of the inguinal canal. The lateral portion of the posterior wall is made up of transversalis fascia. Now that's a lot of information, so let's make it a little bit easier. And note that the roof is made up of two muscles. That's the M here. So the muscles are internal oblique and transverse abdominis. Now if we go to the anterior border, it's made up of two aponeuroses. That's the A. So it's the internal and external oblique aponeuroses. The inferior border is made up of two ligaments. That's the L, the inguinal and the lacunar ligament. And to round out the word, we've got the posterior boundary of the inguinal canal is made up of the conjoint tendon and transversalis fascia. So for each of these letters, there are two structures that make up that particular boundary of the inguinal canal. So this is important, but it may not be easy to visualize. So this next slide may help. If you want to put this URL into your browser, and it is going to take you to Instant Anatomy, which is a good site. I encourage you to look through that, but it'll take you specifically to this handout. So you just push print, and this is the PDF, and you can print out your own do-it-yourself model of the inguinal canal. So this is a paper model. If you do the folds where it is right here, and you cut out the ring, the deep inguinal ring here and the superficial inguinal ring there, then you'll have a three-dimensional structure demonstrating the left inguinal canal. And you can use that, and then you can stick a pencil or your finger through each of the inguinal rings, and you can demonstrate the path of an indirect hernia. Okay, so now we're going back to that Netter atlas illustration of the inguinal canal. This time I've put the labels in so that you can review your anatomy. And then the next I want to show you that if you look at this pathway of the inguinal canal through the boundaries, this is where the spermatic cord exits, and then we can compare that to what it looks like when a loop of bowel passes through those same structures. So this would be an indirect inguinal hernia. And recall that the indirect inguinal hernia exits the abdomen lateral to these guys right here, the inferior epigastric arteries. So it's exiting lateral to that. It's passing through that deep inguinal ring, through the inguinal canal, and if it herniates far enough, it can pass all the way through the superficial inguinal ring here, which has been enlarged to allow for the passage of the hernial sac. And so if this herniates far enough, it can end up in the scrotum. Okay, so clinically, how would an indirect inguinal hernia present? Well, it's important to know that there are varying degrees of seriousness to an inguinal hernia. So you can start out with a reducible hernia. And so a reducible hernia would be one in which the bulge increases with standing or with increased abdominal pressure, but you're able to reduce that hernia either by poking it back in with your finger or by lying back into a supine position, and it will reduce itself. And so a reducible hernia may be positive or negative for pain and tenderness. Now, the next level of seriousness would be the irreducible hernia, and this is also known as an incarcerated hernia. It also may be positive or negative for pain and tenderness. It usually starts out as a reducible hernia, but now it cannot be returned back into the abdominal cavity. And this can lead to nausea and vomiting and signs of bowel obstruction. And that can progress onto what's known as a strangulated hernia. And a strangulated hernia would be one that's irreducible, and it has also then lost its blood supply to that herniated portion of the bowel. And this is going to be positive for pain and tenderness. You may or may not have nausea and vomiting associated with the bowel obstruction, and you may or may not have fever. But a strangulated hernia is a medical emergency and will lead to a hernia surgery. And so a lot of these are done laparoscopically now, in which a a piece of mesh reinforcement, either made out of polypropylene or Gore-Tex or some other fancy material, is placed across the herniation. And I suppose by now you've probably had some experience with testing for inguinal hernias in your med skills, and so I also want to bring up the fact that if a hernia goes all the way through the deep inguinal ring, the inguinal canal, and into the scrotum, it will look like this. Okay, here's your disclaimer of a graphic image coming up, but this is a case of an indirect inguinal hernia. Alright, so this brings me to the aphorism of, if it has tires or testicles, it's gonna give you trouble. Alright, I'm going to leave you with this image here, taken from Clinically Oriented Anatomy. It's a nice image of the difference between direct inguinal hernia on the left and an indirect inguinal hernia on the right, and the chart below sort of compares and contrasts the two. That's all for this podcast. Thank you for your attention, and if you have any questions, please feel free to email me. Thanks so much. Have a nice day.